Hi guys, and thank you for watching. This is Alan Gardner, Senior Lecturer in the School of Sport and Health Sciences at the University of Central Lancashire, and welcome to part one of two of an overview of headaches. This is part one where I'm going to be talking about primary headaches, and I'll tell you more about that in a moment or two. So we're going to go through the different classifications of headache. And then we're going to start with the primary headaches on this video. With regard to the classifications of headache, there's primary headache and secondary headache. Primary, there is no underlying serious cause, whereas with secondary headache, there is an underlying pathology that we need to be concerned about. For example, with primary headache, we have tension headache, migraine, cluster headache, and rhinosinusitis. Now that's not an exhaustive list, that's just some of the common examples, and I'll be going through those within this video. There's going to be a second video, part two of this series, where we'll look at secondary headache with things including, for example, subarachnoid hemorrhage, meningitis, and space-occupying lesion. Tension headache, as you can see from the diagram here, tends to present with a band across the forehead. So with regard to location, it's very much a frontal headache. And this tends to be bilateral in nature. So patients will describe a band of pressure or tightness that kind of comes and goes, or it waxes and wanes across the frontal bone. This is usually associated with stressful times, so if people have work stress or stress within their family lives or other social stresses. I'm recording this at a time during the global pandemic of coronavirus, which I'm sure is going to have a huge impact on stress levels for people, and so that could be manifested as this pain experienced in the front of people's heads. It's the most common cause of headache, and it's also one of or probably the most common reason for people to seek over-the-counter analgesia. With regard to a proposed underlying pathophysiology, it's believed to be kind of multifactorial, that there can be muscle tension and psychological factors that can contribute to this experience of pain. This can be associated with stress and anxiety. It can also be associated potentially with poor posture and even periods of depression. The duration of the pain here can be hugely variable, from around 30 minutes or a few hours up to several days with almost constant headache. It doesn't tend to be associated with any nausea or vomiting. However, because of the multifactorial causality here, there is potential for people to have a decrease in their appetite, and so some subsequent anorexia. People suffering from this type of headache might complain of feeling distracted and unable to focus throughout the day. And they might even have some experience of insomnia as a result of this pain as well. Next up is migraine, and again there's a visualization here to be able to help you picture the differences between these two types of pain, whereas our tension headache is typically this bilateral band of pain across the frontal region. Migraine is a unilateral sensation and a unilateral experience of pain. So it's down the one side of the head and the face, and it's typically characterized by these recurrent attacks. Patients will describe a very gradual onset, and this can be from days in advance of the migraine. People can actually describe something that we call prodrome, which I'll get to in a moment or two. But it's got this typical sort of crescendo pattern. About what I mean by that it has this slow, gradual onset that eventually gets to quite a sort of moderate to severe level of pain. And now what we mean by prodrome is that people will describe a manifestation of migraine well before the pain starts. Now this is a really important thing to explore within the history, that if a patient presents with unilateral headache, starting to understand, or do they notice anything that kind of precedes this? And typical of migraine is this quite sort of broad spectrum of symptoms that people describe, things like irritability or a loss of appetite, insomnia, maybe some muscle aches and pains, even food cravings or difficulty concentrating. Now, migraine can present with or without prodrome, just as we have, if you look at the next thing on our list, which is this idea of aura, that migraine can be with or without aura, whereas prodrome can occur a few hours or possibly even days before the migraine. Aura tends to be a few minutes up to an hour before the actual pain starts. The difference between prodrome and aura is that aura tends to be a visual manifestation of migraine. Again, this happens before the actual headache starts. Aura's visual manifestations can be characterized as either negative, so some loss of vision, or positive, which is these visual scotoma, as they're referred to, interferences with the vision that are superimposed on top of what the patient's able to see. Most commonly is that patients describe this sort of arc of like wavy lines that are superimposed over their vision. This is referred to as the scintillating scotoma. This is like a wavy line or arc of absent vision with coloured zigzag lines around the edge of it. But patients can even complain of absence of visual fields on the same side as the headache. The duration of migraine tends to be several hours up to 3 days. So patients have reported migraine that's lasted 72 hours. It comes with a long list of associated symptoms as well, including nausea and vomiting. Quite typically, photophobia, so patients will complain of a real sensitivity to light. They'll feel the urge to go and lie down in a dark room until the pain passes, and even phonophobia as well. So that means an irritability or an intolerance to certain sounds, in particular quite loud sounds. The pain itself tends to be described as throbbing in nature, or they might describe it as pulsatile as well, as it tends to be felt around one side of the head, around the frontal or ocular region. It can also be felt anywhere really down one side of the head and even into the neck as well. Whereas migraine is a much more common type of headache, statistics demonstrate that in the United States, for example, as many as 30 million people have one migraine every year. Cluster headaches is much less frequent, much less prevalent, I should say. The prevalence of cluster headaches is estimated to be about 0.4% in men and 0.08% in women. Cluster headache is a group of idiopathic headaches and trigeminal neuralgia. What this means is that it's quite a poorly defined, it has a poorly defined etiological cause that we don't really understand exactly what causes these headaches. And whenever we're trying to diagnose a neuralgia, this is actually a diagnosis of exclusion. So we actually have to exclude all other causes before we can then say, well, this is caused by a neuralgia. Cluster headaches have a unilateral presentation. They tend to begin very rapidly. Patients will describe a very sudden onset, or should I say a very, very fast onset of pain, and it tends to be around the eye and the orbit bone. They'll describe a deep and continuous pain, and it's quite excruciating and explosive in quality. These headaches tend to last between half an hour up to about 3 hours. And as the name cluster suggests, that these attacks tend to come in episodes of sort of groups of headaches that occur one after another. So patients might say they have one headache a day for several days, followed by a period of remission, or they may even have up to 8 periods of a headache within a day. These attacks are associated with a list of associated symptoms. So they will come with one or more of the following. So that includes conjunctival injection, which is a widening of the blood vessels within the conjunctiva. They may have lacrimation or nasal congestion or rhinorrhea, so a runny nose. They may have forehead sweating or facial sweating. And you can see on this list it mentions Horner's syndrome, which is ptosis and meiosis. So Horner's syndrome includes ptosis, which is the drooping of the upper eyelid, and meiosis, which is excessive constriction of the pupil. As it mentions in this list, now these associated symptoms are all associated with the function of the fifth cranial nerve, which is why, although the actual pathophysiological mechanism of cluster headaches is quite poorly understood, that there's definite involvement of the fifth cranial nerve, which is why it's this group of idiopathic headaches that's associated with the trigeminal nerve. The final primary headache I'd like to talk to you about is rhinosinusitis, and you probably don't typically think of rhinosinusitis pain as a headache, but patients can present with a presenting complaint of I have headaches, as opposed to, well, you would expect them to complain of facial pains. But as we know, patients don't always present with the terminology that we anticipate. And so they might interpret this pain as a headache, or they might have very, very little facial pains, and that their main concern is that they have referred pain to the top of the head, or their temporal regions, or into the occiput. It tends to be maxillary pain or frontal pain that patients will describe. The characteristic of the pain as being like a pressure within their face, or as I say, radiating into other regions of the head. This is because the paranasal sinuses are very sensitive to pressure changes. So the pathophysiological cause of this is, well, you can see in this diagram that we've been through the anatomy of the nose previously, that we have these turbinates inside the nose and these internal meatai in between the turbinates, and as you can see in the blue maxillary sinuses here on this diagram, that these sinuses drain. If I just draw a line here, actually they drain into the nose in this direction, so they create mucus that have to drain through these meatai, and if they become blocked, then the sinuses themselves aren't able to drain, and so we find we get an increase of pressure within the sinuses. Now, in severe forms of acute rhinosinusitis, they can become infected, and so we see purulent discharge from the nose or down the back of the nose. So we have a long list of associated symptoms that these people will come complaining of facial pain or headache, and that this tends to be bilateral in nature. As I've said before, anything unilateral in ENT is very much a cause for concern, and that should be seen as a red flag. So they'll complain of nasal blockage. That might be only on one side, or it might be on both, or it might even change from one side to the other. They tend to have a respiratory tract infection in in the run-up to complaining of facial pains. So it says here that we should be suspicious of acute rhinosinusitis in patients that have had a persistent respiratory tract infection that lasts 7 to 10 days or longer than that. It's significantly longer than 10 days, and you'd be considering now chronic rhinosinusitis. Patients might complain of a sensation of mucus dripping down the back of their throat, and actually on examination, as we examine the mouth and oropharynx, we might be able to visualize some discharge down the back of the nose into the posterior oropharynx. They are likely to complain of anosmia. So well, anosmia means an absence of sense of smell. It might not be entirely absent. It might just be decreased, or they might say that they can smell sort of unpleasant odors, especially if they have some bacterial infection there as well. They might have some edema around their orbit bones, or periorbital edema, and that might even progress to periorbital cellulitis, which would be a red flag in this case. So this actually brings us now to the end of this short introduction to primary headache. As I said before, this is only part 1 of a 2-part series, which I'll be releasing shortly. So thank you very much for listening and watching, and I will see you soon. Thank you.